Thanks, Kent. Hello, everyone. So today's talk is on initial antiretroviral therapy, and this may sound similar to what I talked about before with the guidelines, but I want to get a little deeper into how we choose an antiretroviral therapy regimen with a new patient coming in. And I'll just say that this is one of the essential skills for an HIV medicine practitioner as you start to get a little more advanced and see new patients or start your own patients on new therapy as opposed to just inheriting them. Kind of one of the most essential skills, I'd say, next to interpreting resistance testing. So here we go. And I feel like this talk might be outdated already, having been to Croy all week and seeing all the exciting new treatments that are out there, but this is the status as of now. So again, a lot of the information I'm going to present to you is in this document, which is continuously updated. I just show it for the reference on the bottom. I think the best way to access this is via the website, aidsinfo.nih.gov. Mainly because all of the other guidelines are there as well. And as new things are updated, they're updated on the website before a print document can be updated in October 2000. So I'm going to start with selecting among the 4 preferred regimens, and by way of background, I showed you this graphic in the last talk just as a picture of what we have available to us. The 3 main classes that we're talking about are NRTIs, NNRTIs, and protease inhibitors. And then we have 2 additional classes, the integrase inhibitors and the entry inhibitors. And of course, entry inhibitors are not really considered part of initial therapy at this point. So we'll talk about the other 4 classes. And again, I told you I don't like to show this to too many people because it's overwhelming, but now we're going to get a little deeper into this chart. And I know I'm going to use a lot of names that you may or may not be familiar with. I've tried to bold them in the talk wherever possible. And I've also tried to use the 3-letter code that we often use as shorthand for these antiretroviral drugs. And like one of my medical school professors told me, repetition is the branding iron of knowledge. And so just hearing these more and more and more, you're going to get a little more and more familiar with them each time. So again, the recipe, if you will, for starting antiretroviral therapy in a naive patient looks like this. And we start with a backbone of a 2 NRTI combo, and onto that we add a 3rd agent, either an NNRTI, a PI, or an integrase inhibitor. But I'm going to get a little deeper into this with how you would think about it with a patient in front of you. So I think of it this way, using this schematic. There's some key factors influencing what you're going to choose in terms of a first-line regimen, and they have to do with the virus itself, the antiretroviral drug, and then the host. So first, with respect to the virus, there are some things that are important to consider. The baseline viral load, the tropism if you're going to use a entry inhibitor, but those aren't as important for initial therapy, mainly because all of the regimens that we choose are very good at high viral loads as well. But transmitted resistance is a really important factor, and that's why we always get a baseline genotype on a new patient to make sure that they're not resistant to any of the medicines that we would choose kind of de novo. Secondly, we think about the drugs, and this is what most of the talk is going to be about, whether things are tolerable, what the side effect profile looks like, and then obviously efficacy. We like using regimens that have long-term safety records, that have low drug-drug interactions, and that have good pharmacokinetics that would allow once-daily dosing. And then pill burden is a major concern for most patients and should be for us. Cost is less so, but these days it might be coming up more and more as patients are struggling to get insurance coverage through drug programs. And then probably most importantly is the host. You, as clinicians, know that every person that comes into your office is very different, and they all have different values, I would say. And one of the most important first things is just to identify who they are, and then what's most important to them. Are they very side effect averse? Do they have medical comorbidities or other medicines on their med list that you need to think about? What's their lifestyle? Are they somebody that's going to be up all night, in which case choosing something that might give them nighttime side effects would be a key concern. And then we try to look into our crystal ball and think about adherence. I'll talk about that a little bit later. What kind of adherence do you think they're going to have? The HLA B5701 is probably less important because abacavir, which is what that test is for, to see who is going to have an abacavir hypersensitivity reaction, is not part of any of the preferred regimens. And then at the end here in bold, I have patient preference. So I really see this first visit or the visit where you're planning antiretroviral therapy to be one where you are providing options and then allowing the patient to choose. And you're bound to get a lot more buy-in if you put a couple of options out there and then let the patient decide so that they feel like they're really involved in the decision-making process. So again, here's the 4 regimens that I referred to, and you see pictures in terms of the pill burden. The first being Atripla, or Efavirenz-tenofovir tricytidine. The second 2 being protease inhibitor-based regimens, where you have Truvada, the blue pill, as the backbone. You have the white pill, ritonavir, as the booster agent, and then you have either Atazanavir or Darunavir added on top of that. And the last regimen here is the Raltegravir-based regimen, which you can tell by the dividing line there is a twice-a-day regimen. We're going to get into each one of these in a little more detail. So first of all, an Atripla-based regimen. You can see just a single pill up on the top corner there. This currently is alone as being the only single pill once-a-day regimen, and the advantages here are that it's really had a long history as being the gold standard. When this has been looked at head-to-head, it's never really lost a head-to-head trial compared to a lot of the other agents. It's the only regimen that's 1 pill once a day, although that probably will change within the next year or so. And it's really appropriate for TB co-infection. The disadvantages are there is a relatively low genetic resistance barrier. If you do have failure and resistance to the NNRTI component, there's a higher risk of NRTI resistance as well. And the main one here is CNS adverse events, things like dizziness, vivid dreams, neuropsychiatric effects that are really the main limiting factor in terms of side effects. It is thought to be teratogenic in the first trimester, although there's been some recent data and some guidelines that have questioned this in European guidelines, but we still consider it something to avoid in a woman of childbearing age. And then there are potential drug-drug interactions, mainly to do with the efavirenz component. And I just show in each of these slides some of the major trials that have been done. This one, the ACTG 5202 trial that compared efavirenz with Atazanavir ritonavir. The second would be an Atazanavir-ritonavir-based regimen. You see the pill count up on the top there. The advantages are that it's been shown to be equivalent to efavirenz, the gold standard, in the previous slide I just showed you, the 5202 study. Atazanavir really has fairly favorable lipid effects in terms of compared to the rest of the protease inhibitors. It has a very low resistance risk at failure, and this is something that's a little bit paradoxical to understand, but if you look at trials where Atazanavir has been used, even in the patients that have quote-unquote failed and had virologic breakthrough, they do not tend to have drug resistance. So what's really happening there? Maybe it's an adherence issue, but it's kind of a low risk of resistance, and that comes into consideration when you think about a patient's projected adherence. This regimen is also a once-a-day regimen, but does contain 3 pills. And I have both as an advantage and as a disadvantage that there is 100 milligrams of ritonavir. That's a lower dose than some other regimens that have been used in the past, but it still is 100 milligrams of ritonavir, and sometimes that's enough to give people side effects. The disadvantages here, the main one, the absorption is decreased with acid-reducing agents such as H2 blockers or PPIs. We'll talk about that a little bit later. Secondly, there is unconjugated hyperbilirubemia, which is an asymptomatic condition and stops upon cessation of the drug, but this does happen in up to 10% of patients, and for some people, it actually can be disturbing if they are in front of a camera for their work, or if they're a host at a restaurant, or if they just don't like the scleral icterus that can come along with this. There are some food requirements for dosing. There are no real co-formulations available, so you have to take this separately. And again, does require ritonavir, which in some cases is enough to cause enough gastrointestinal side effects for people not to want to take this regimen. Moving on to Darunavir, this is our other protease inhibitor-based regimen. This is considered really the most potent protease inhibitor, and in terms of salvage regimens, it's a great drug to go to, but it's also been studied in initial therapy. It also has relatively favorable lipid effects, mainly when compared to the older regimens such as Kaletra or lopinavir ritonavir. Again, just like Atazanavir, there's a low risk of resistance at failure. This is a regimen that has 4 pills once a day, and again, you still have 100 milligrams of ritonavir as part of the regimen. In terms of the disadvantages of Darunavir, there is a rash that's been seen. I've seen it in several of my patients. Overall in the trials, it's about a 6% rate. And there's thought to be a risk in sulfa-allergic patients because there is a sulfa group as part of the Darunavir molecule. Personally, I've used it in sulfa-allergic patients, just being very careful. And I've also seen rashes in non-sulfa-allergic patients, so that's just an important consideration to watch out for. There are no co-formulations available of this drug as of yet, and unlike the others, there's been really no head-to-head comparisons with other regimens. You see on the right here the Artemis trial, and the Odin trial is another one that's been done, but it was comparing Darunavir to lopinavir-ritonavir, which is not in the recommended 4 regimens. And then lastly, again, this does require ritonavir, so sometimes some people have trouble with that. So lastly, the 4th regimen is a Raltegravir-based regimen. You can see this is a twice-daily regimen paired with Truvada. And this has comparable efficacy to Efavirenz at a 4-year follow-up, regardless of baseline CD4 or viral load. You can tell it's a Raltegravir study when you get into the chart that looks a little different in this on the right here, the start mark chart. And part of the reason is because Raltegravir is known to have a really fast decay in viral load. So you can see that purple line there. The Raltegravir group decayed a little bit faster than the Efavirenz group. With Raltegravir, one of the other advantages is we're seeing very few drug interactions. We have a very favorable lipid profile. And whether this is clinically relevant or not, we're not quite sure, but had a slightly higher CD4 increase than Efavirenz in one of the studies. Major disadvantage of this regimen is it requires BID dosing. It's considered to have a relatively low genetic barrier to resistance, similar to NNRTIs and lower than the PIs. There is a risk of NRTI resistance with failure. And again, there's no co-formulations at this point in this class. There is a potential for skin reactions as with any other drug. And it's really only been tested so far with a backbone of FTC and TDF or Truvada, not a lot of other nuke compounds that have combinations that have been used. So what about individual patient factors? I've gone through the drugs themselves, and we're going to go through individual factors that might influence your decision as well. The first consideration is high viral load. So what's been shown in a couple of recent trials is regimens that looked pretty good having some degree of failure in patients with very high viral loads above 100,000. Interestingly, all of the 4 agents here listed first, Efavirenz, Atazanavir, Darunavir, and Raltegravir, have all performed very well in high viral load strata. So actually, we don't really have to worry about this too much in our preferred regimens. I have a note on the bottom here about Epsicom and about Complera, which are listed as alternative agents, and there's concern in both of those medications with higher failure at high viral loads. But like I said, for all of the preferred regimens, any viral load, it looks like there's equivalent efficacy at all strata. This is a harder thing to talk about, adherence concerns. I would say this is more of a personal opinion than something that's been borne out in clinical trials. But when we have patients that we are concerned about their adherence, regimens that are Efavirenz containing or Raltegravir containing are a little bit more concerning due to the lower genetic barrier of resistance of these 2 agents. In addition, the long half-life of Efavirenz compared to the other 2 agents that are in Atripla, the M-tricytamine and tenofovir, does make it vulnerable in terms of drug resistance due to the shorter half-life of the other agents. So for example, if somebody takes their 5 days of Atripla during the week and then stops and goes out and parties on the weekend, they're probably going to have more Efavirenz monotherapy exposure as the other half-life of the 2 other drugs are tailing off, and that would be a perfect situation to develop Efavirenz resistance. On the other hand, protease inhibitors, such as Atazanavir and Darunavir, have a higher genetic barrier to resistance and a low incidence of drug resistance on failure. So for me personally in my practice, if I have somebody where I'm a little bit worried about adherence, I do tend to try to go with a protease inhibitor regimen. Viral hepatitis is something very important. I'm glad to see John Scott in the room. We really have to consider this in our patients before starting them on antiretroviral therapy. So testing for hepatitis B and hepatitis C is recommended on initiation of care. For hepatitis B, it's important to know that M-tricytamine, tenofovir, and lamivudine all do have activity against hepatitis B. And so for a starting regimen, it's preferred to use something that contains 1 or 2 of these agents, which in our 4 regimens really, since Truvada is our starting NNRTI combo of choice, that's kind of covered. But it's also important to remember that if you're switching therapy later or you're discontinuing therapy for some reason, you need to be aware of rebound of hepatitis B if one of these active agents is removed. For hepatitis C, there is not a lot of guidance on this, but just having watched a lot of presentations from Croy about drug-drug interactions with the new medicines for hepatitis C, it's looking like Raltegravir is going to be a great regimen to combine for somebody that might be treated for their hepatitis C. Drug-induced liver injury is also more common with ART in people that have hepatitis C co-infection, but most of this data is for the older agents such as nevirapine, D4T, DDI, and higher dose ritonavir, which we're not really using anymore. So for hepatitis C, if you have somebody that you're thinking about in the future treating them with a hepatitis C protease inhibitor such as boceprevir or telaprevir, it looks like raltegravir is your regimen of choice in that case. Cardiovascular disease comes up a lot, or hyperlipidemia, and the big question is how will the ART that you're going to give your patient affect their lipids? So in general, protease inhibitors increase lipids, but Atazanavir and Darunavir, our two preferred protease inhibitors, have risen to the top, mainly because they are better than lopinavir, ritonavir in terms of their lipid effects. Efavirenz always used to be thought as more of a neutral agent, but in especially the ACTG 5202 study, did adversely affect cholesterol more than Atazanavir, and in other studies more than Raltegravir. So also in terms of lipids, Raltegravir appears to be the most neutral with respect to lipid changes. I'm just going to mention that abacavir has been the subject of a lot of controversy related to cardiovascular risk. I think the verdict is not completely out yet, but people do get a little bit nervous with respect to abacavir. Also another reason why this has been moved away from the preferred agents list. Renal function is concerning as well. Truvada, or the tenofovir component of Truvada, is really the active agent in terms of renal function. So first of all, if your patient has renal impairment and you have to adjust the doses of some of the ARVs, you're probably not going to be able to use a fixed dose combination. You might have to take apart those individual agents. Tenofovir might be something to avoid in a patient with renal impairment. I think we'll see that in one of our cases today. And then cumulative exposure to Atazanavir as well has been associated with renal dysfunction. I think it's important to consider women of childbearing age, not only because they may become pregnant, but also efavirenz being the main concern here about being teratogenic in the first trimester. There is more limited data in Raltegravir and Darunavir in pregnancy, and as I alluded to earlier, combivir and lopinavir are actually the preferred agents in pregnancy. However, they're kind of antiquated at this time. There's a lot of discussion in the CROI meeting this week about whether more modern regimens such as Truvada and Atazanavir would be acceptable. And I would say in our Madison Clinic practice and in Dr. Jane Hitty's practice, Truvada and Atazanavir probably is the most preferred agent in this situation. I think lastly, dyspepsia or GERD is an important consideration, mainly to do with Atazanavir concentrations. But just keep in mind that for newer agents such as rilpivirine, sometimes this does come up. If your patient's taking omeprazole or ranitidine, it's really important to keep an eye on this because drug interactions can decrease the efficacy or the absorption of your Atazanavir. And there are recommendations that you need to you need to space out the dose 12 hours apart from the Atazanavir dose. There's also some evidence that Raltegravir concentrations can be increased. Lastly, psychiatric disease. In 10 seconds, I'm going to cover this very complicated issue about efavirenz dosing in patients with psychiatric disease or using Atripla. In general, we stay away from people that have had mania in the past, bipolar disorder, schizophrenia, and I consider people with really severe PTSD where you may cause vivid dreams to be very cautious in this setting. But we do have a lot of patients with depression or kind of more mild mental illness in which we start Atripla and just watch carefully and are usually okay with that. I'll just mention Complera has been seen to have less neuropsychiatric effects but more virologic failures, and that'll be the subject of a different talk in the future. Final couple slides on what about using a non-preferred regimen. I just want to flash this in front of you very quickly to say that there are other regimens out there which are acceptable. For example, if you cannot use Truvada as your backbone, these four are basically the starting regimens but just with abacavir lamivudine as your nuke backbone. You can see rilpivirine has kind of risen to an alternative regimen, not quite preferred. And then also in the acceptable regimens, this is where these other agents come in, such as maraviroc and such as nevirapine, which is still kind of considered acceptable. So in summary, we have 4 preferred regimens that all have extensive safety and efficacy experience through many clinical trials and in all viral load strata. And these include the third agents of efavirenz, Atazanavir, Darunavir, and Raltegravir. And they each have really specific advantages and disadvantages that must be discussed really with the patient to make the best decision for that particular patient. Patient-level factors such as childbearing potential, co-infections, comorbidities, and other meds should be considered when selecting the ideal ART regimen. Occasionally, an alternative regimen may be appropriate in certain circumstances, and of course, respecting the patient's opinion and involving them in the decision-making is really, in my opinion, going to probably affect adherence when they feel involved in the process.